Apnea of prematurity is one of the most common diagnoses in the NICU. But for anybody who's ever worked with babies, you'll know how many unanswered questions we have about apneas. So what actually defines an event? How bad is it for a baby to have one event or 10 events? And how should we be actually treating apneas? Hello, I'm Dr. Tala and I've been a neonatologist for 16 years now. And in this video, we're going to get to the bottom of some of these questions today. Also, make sure that you stick around to the end because I'm going to give you a homework assignment on apneas. Today, we're going to divide this video into 4 parts. 1, what is apnea of prematurity? 2, how do we treat apneas? 3, what are the outcomes of infants with apneas? And 4, when can we send babies home who have had events? Right, let's start with 1. What is apnea of prematurity? If you are going to get one thing from this video today, then realize this, that apnea of prematurity is a diagnosis of exclusion. So there isn't actually a test that tests for apnea of prematurity where you can categorically say, oh yes, this is definitely apnea of prematurity. But there are tests where you can actually rule out other causes of the apnea. So let's just say that you have a 5-day-old X28 weeker who suddenly starts having a lot of events that need stimulation. You can't just be like, oh, well, that's obviously apnea of prematurity. Let's go up on the caffeine dose a little bit. Obviously, you have to make sure that you're not missing something else. And just about an abnormality in any system can cause apnea. There is such a long list of why babies can become apneic, including that the baby is cold or septic or develop neck, or the baby's having seizures or HIE. There could be metabolic causes like hypoglycemia or hypocalcemia, or there's an IVH or other neurological problems. Maybe the baby has cardiac anomalies or other congenital anomalies, including airway issues. So the list of what can cause apnea in a baby is very, very long. If you're pretty sure that none of those other things are going on, then yes, you call this apnea of prematurity. But let's start with what actually defines an apneic event. Generally, apnea is defined as cessation of breathing, so the baby stops breathing altogether for 20 seconds. It can also be considered an apneic event if it lasts less than 20 seconds, but if the cessation of breathing is associated with either bradycardia or a desaturation. So a bradycardia would be a heart rate less than 80 to 100, depending on what you have in your hospital, and a desaturation would be a pulse ox reading less than 80 to 85%. Also, if the cessation of breathing is associated with a color change in the baby, so the baby actually appears cyanotic, so that could be in the newborn nursery where the baby isn't actually on a monitor, or the baby looks pale, all of those different things can be considered an event. So again, an apneic event if a baby stops breathing for 20 seconds, or stops breathing for less than that, but it's associated with bradycardia or desaturation or a color change in the infant. So to further classify apnea, it can be subdivided into 2 different groups, which are basically dependent on what's causing the apnea. And that is 1, central apnea, and 2, obstructive apnea. Central apnea means when the baby literally isn't taking a breath. And we call it central because it's part of the central nervous system. Either the baby's brain is immature or there's something going on with the brain. And I explain this to parents as saying that literally the baby's brain is forgetting to tell the baby to actually take a breath. So the baby is just not breathing. And 2, obstructive apnea. Obstructive apnea is where the baby is actually taking breaths, so you can see the baby's chest move, but there is an obstruction for the air to get in and out. We see this a lot in older patients, and this is often what parents think about when we tell them that their babies actually have apnea. They're imagining the older adults that have sleep apnea, for example. So they need the CPAP mask on all the time when they're sleeping to kind of try to stent everything open and make sure that there's no obstruction to the airflow. We also do see some type of obstructive apnea in these babies as well, and normally that obstruction is at the level of the pharynx. We always think about preemie babies only really having the central apnea, but really most of the events that babies have are really a combination of both central and obstructive events. There are so many factors implicated into why premature babies are so sensitive to getting apneas. And really, they're all related to the immaturity of the autonomic system. So the nervous system that we don't think about normally happening. For example, premature babies have decreased central chemosensitivity. So even though the carbon dioxide is building up in a body, in an older patient, that would automatically be a trigger for that baby or that person to take a breath. But because of the immaturity of the chemosensors in premature babies, it doesn't necessarily trigger the baby to actually take a breath. This is table 1 from the AAP's review article of Apnea of Prematurity, kind of just going over some of those factors. This was a great review, by the way, published in 2016, and we got a lot of information from the talk from this review article. Who gets apnea of prematurity? Well, as you'd expect, the younger the gestational age, the higher the chance of the baby having recurrent apnea of prematurity. In one study done by Henderson Smart, they showed that all babies born at less than 28 weeks had apnea of prematurity. At 30 weeks, about 85% of babies have apnea of prematurity, and at 34 weeks, about 20% of babies have apnea of prematurity. So, as a quick aside here, in the US, we automatically admit any baby born under 35 weeks to the NICU. And this really is one of the reasons why, that there still is a pretty high chance of this baby having apnea of prematurity. It's also why when we do admit babies to the NICU, we automatically put them on a heart rate and pulse ox monitor. In this study by Henderson Smart, they found that 92% of the events had stopped in babies by the time they were 37 weeks. And 98% had stopped by the time the babies had a post-menstrual age of 40 weeks. They found that the babies that were most likely to still be having the events by the time that they're of term age were the babies that were born the earliest, as well as the babies that had BPD, so who were still on significant respiratory support. And the natural course of apnea of prematurity has been well described. And anybody who's worked in the NICU has seen this. So when the babies are really little and small, they're having these pretty frequent, pretty severe events where they're needing vigorous stimulation or maybe even positive pressure ventilation. As the babies get older, not only do the events become less frequent, but generally less and less stimulation is needed to get the babies out of it. And then really kind of when they're getting closer to going home, a lot of these babies can bring themselves out of it without needing any sort of external stimulation. So this is all fine and dandy. We can define and describe an apneic event all day long, but anybody that actually works in the NICU knows how hard it is to actually record and then document an event. So most of the time we have our babies on a continuous heart rate monitor, continuous respiratory monitor, as well as a continuous pulse ox. And then we set different parameters for alarms to go off if the heart rate's gone too high or too low, and the same thing with a pulse ox. Normally we set the cardiac alarm at 100 beats per minute. So if the heart rate falls below 100, the alarm will go off. Sometimes as the babies are getting older, or if the baby has a low resting heart rate, then we'll set that alarm lower. Apnea alarms are set at 20 seconds. So if the baby doesn't take a breath for 20 seconds, then that alarm will go off. So this is kind of part of the problem, that everybody that's taking care of a baby knows just how inconsistent those respiratory rate alarms really are. So sometimes the baby could be breathing and the alarm goes off. Sometimes the baby hasn't taken a breath for ages and the monitor is actually measuring the baby's movement or the baby's heart rate or something, and it doesn't go off at all. Different units, just like the heart rate, will have their pulse ox parameters set at different levels. Normally it's somewhere below 80 to 85%. What's also interesting is that different units keep on their pulse oxes on their babies for longer periods of time, so closer to them going home. And generally, it's been found that the units that keep the pulse oxes on for longer generally have babies with later discharges. So those babies are going home older. So what this probably means is that a lot of these babies are probably having kind of slight desaturations that aren't being picked up because in other units, those babies are not on pulse ox machines. So you can see that even though it's very easy to define what an event is, in reality, it's much harder to actually document it and then record it and decide what is actually clinically significant, which is why it's so important that every single unit has their own protocols in place where as a team, everybody decides exactly what and when everything should be recorded. But in a nutshell, if somebody is asking you what is apnea of prematurity, apnea of prematurity is an apnea that mostly happens in premature infants because of the immaturity of their autonomic nervous system. Generally, the babies will outgrow the apnea of prematurity, but we have to support them through it until they've outgrown it. If a baby has sepsis or NEC or has a bad IVH, then that baby may develop apnea because of those etiologies, but that is not considered apnea of prematurity, and obviously those diseases need to be treated accordingly. So one really important aspect of taking care of babies with apnea of prematurity is kind of getting their baseline. So maybe the baby that you're taking care of has 1 to 3 events a day, maybe needing mild stimulation or no stimulation. The baby's self-recovering. If that baby starts having 10 events a day needing positive pressure ventilation and vigorous stimulation, this is a massive change, and you can't just say that that's apnea of prematurity. So like a lot of what we do in neonatology, it's really good establishing the baseline of where your baby is. 2, let's talk about the treatment of apnea of prematurity now. Well, as everybody knows, methylxanthines, of which caffeine is one, have been the mainstay of treatment for a long time now, which I can't tell you how much I love. I can't tell you how much I love coffee. So I just love the whole kind of completion of the circle that the babies get to get caffeine as well. Historically, theophylline was used, which is also a methylxanthine for apnea of prematurity, but it has a small therapeutic window, which means that it has to be under very tight control. If you give a little bit too much, then the baby could overdose on it. The good thing about caffeine is that it has a much larger therapeutic window, and it also has a longer half-life. And because of that, we don't have to monitor levels of caffeine at all. As you all know as well, we can also give caffeine IV as well as PO. I always tell parents that caffeine is a central nervous system stimulator, because it is. And so when we're giving it to babies, what we're really trying to do is literally remind them that they need to take a breath. Really, this isn't the full picture, because it never is. In reality, caffeine works by inhibiting and stimulating a bunch of different adenosine receptors. I'm not going to get into that here because it's not that clinically relevant. But thank you so much to everybody that's done the research in this. But overall, methylxanthines increase minute ventilation. So basically, each baby will have a higher tidal volume, like taking bigger breaths in and out or breathing faster. It improves carbon dioxide sensitivity, decreases periodic breathing, decreases hypoxic depression of breathing as well. So really lots of good things. Also, caffeine is probably the best studied drug in the unit. The largest trial done investigating caffeine and its effects on apnea of prematurity and everything was done in 2006 by the Neonatal Network. It was such a brilliantly done trial and recruited so many babies, and the results were so clear that there really is no point in repeating this trial. So in this trial, they recruited 2006 babies in the year 2006. How perfect is that? And then randomly assigned these babies either to receive caffeine or a placebo in the first 10 days of life. And the babies were included if they were born at a birth weight between 500 grams to 1,250 grams. The babies were started on a bolus dose of 20 mg per kg of caffeine, and then started on a maintenance dose after that of 5 mg per kg per day. That could be increased to 10 mg per kg per day if the babies were continuing to have bad apnea. So going into this study, it had already been pretty well established that caffeine does reduce the frequency and severity of apneas of prematurity. However, the results of this study was super impressive, not necessarily just because of the apnea of prematurity, although they're probably all related. What this study found is that the babies that had received the caffeine had lower days of being intubated. They had decreased incidence of BPD, so basically decreased oxygen or respiratory support at 36 weeks gestational age. And as if that wasn't enough, they also had, the babies that received caffeine, improved neurodevelopmental outcomes at 18 months of age. In fact, the babies from this cohort have been followed up every few years. And really, at just about every stage, it's shown that there are some developmental advantages to having received caffeine when they were babies. The most recent cohort published, the babies are now 11 years old, so basically in middle school, and there are still some developmental advantages at the age of 11 of having received caffeine. How impressive is that? Other follow-up studies have also suggested that starting caffeine earlier rather than later is also better for these babies in terms of BPD and how long they're intubated for. So a lot of times we start caffeine shortly after the babies are born, immediately in the NICU. But now that we're having babies born younger and younger, the question really does come up. Should we be starting caffeine on these babies when we know that we're probably not going to be extubating them for a couple of weeks at least? So if we have a 22-weeker born, should we be starting that baby on caffeine immediately as soon as the baby reaches the NICU? Dr. Schmidt, who was the first author on the initial massive trial on caffeine, recently wrote in an editorial that premature babies should be started on caffeine when they're becoming candidates for extubation and not necessarily before then. So her argument is that we probably shouldn't be starting a 22-weeker on caffeine as soon as they get to the NICU. And I think this sums up a lot of what actually happens in neonatology and medicine as a whole, and that is called therapeutic creep. And it's very logical of us to all think like this. Well, if a little bit of something is good, then maybe lots of something is really good. And that could also be happening with caffeine as well. And we know from different surveys that have been done and published that different units all over the world use massively different doses of caffeine. Some units use up to 80 milligrams per kilo as a bolus dose, and then up to 20 mg per kg as the maintenance dose. So really very wide range in caffeine. There isn't a lot of data available on whether these higher doses of caffeine are better or bad for babies. What is known, and thanks again to the researchers, is that at the standard doses of caffeine, so 5 to 10 mg per kg per day, the adenosine receptors are fully inhibited or stimulated. And that's what's needed for the respiratory effect. So really, what are these higher doses of caffeine doing? One study suggested that a higher loading dose of caffeine may increase the risk of having cerebellar hemorrhages. So not a good thing at all. Should we be measuring the levels of caffeine in blood? Well, again, for anybody that works in the NICU, you're all very aware of the fact that we're not doing this, and there's a reason. We really don't have to. Like we already said, caffeine has a wide therapeutic effect, and also there isn't any very strict dose level response. So it's not like if this is exactly the level of the caffeine, then this is what we'll expect to happen. So we don't gain anything from actually checking caffeine levels. The next logical question is, when do we stop caffeine? And we'll talk more about that in the section of when babies can go home from their events. So, in a nutshell, we treat apnea of prematurity with caffeine. The standard bolus dosing to start off the course would be 20 mg per kg given once, and then a maintenance dose of between 5 to 10 mg per kg per day. This can be given IV or PO, and there are very wide variations. It should be started in most premature infants, so definitely less than 30 weeks, and then depending on whether they have symptoms of apnea of prematurity or not after that. Caffeine doesn't just decrease the incidence and the severity of apneas of prematurity, it also decreases the chance of the baby having BPD, and if anything, improves neurodevelopmental outcomes. So we're all about the caffeine. After that little love message to caffeine, let's talk about other treatments for apnea of prematurity. So the first one that we'll talk about is respiratory support, or at least increasing respiratory support, and we've all done this in the unit. And that is, if a baby is having more events, then we'll generally escalate the respiratory support. So for example, if you had a baby that had 5 very severe events in the last hour needing vigorous stimulation or positive pressure ventilation, then what are you going to do? At that point, you're probably going to actually intubate the baby. Obviously, when we intubate the baby and put them on the breathing machine with a set rate, then that baby isn't going to be apneic because the breathing machine most of the time is going to be actually breathing for the baby. So yes, obviously we can use increase in respiratory support to give the support that babies with apnea of prematurity need. Similarly, CPAP, so continuous positive airway pressure, has also been shown to decrease the incidence and severity of apnea of prematurity. Probably just like in the older adults that use the CPAP at night for their sleep apnea, then probably what it's doing is just kind of stenting over the airways. So just kind of making sure that there's really a decreased obstructive component to that apnea. We even sometimes say that just kind of having that CPAP mask on is enough to kind of remind the brain that it needs to be taking breaths. In various studies, high-flow nasal cannulas have also been shown to reduce the incidence of apneas, although that evidence really isn't as robust as the CPAP evidence. What about blood transfusions? So, like a lot of the evidence and a lot of the research published on blood transfusions, it is so difficult to tell whether blood transfusions are helpful, and if so, at exactly what level of anemia. Since the red blood cells actually carry the oxygen around the body, you'd assume that by having a higher hematocrit and more of those red blood cells, the babies would have more reserve and so less likely to kind of tip over into a severe apnea of prematurity. And some data does show that babies with lower hematocrits are more likely to have more apneas, and that giving a blood transfusion can decrease the number of those apneas in the short term at least. So not a lot of concrete advice here. Consider a blood transfusion if the baby's hematocrit is really low and you really don't have other reasons why this baby's apnea of prematurity has gotten worse. 3. What about treating for reflux? Well, anybody who's taking care of a baby in the NICU would categorically say that the baby has more events when they appear to be having worse reflux. Nurses will record milk coming out of the baby's nose at the same time that the baby is having an event, or will be at bedside and the baby's super uncomfortable and arching and grimacing and is actually having an event. So everything really seems to coincide with that event happening at the same time as the gastroesophageal reflux. But somehow, this has never been proven in literature. In fact, pretty solid studies have shown that reflux and events are unrelated. Anyway, if you've been watching any of our videos at all, you'll know that we don't want to treat reflux with medications at all. We know that treating reflux with the medications like with Zantac or with a proton pump inhibitor increase the incidence of necrotizing enterocolitis, as well as mortality. So we completely avoid treating for reflux anyway. So just like with the apnea of prematurity, what do we have to do with reflux? Wait for the babies to mature and get older and bigger and for those reflux symptoms to wane. So in summary, do not treat the reflux, don't give medications for the reflux in an effort to decrease the apneic events. 4, and the last kind of treatment of apnea of prematurity that we'll cover is positioning, or the position that the baby is in. This isn't a real treatment, it's kind of more preventative, but we've all seen that if the baby is kind of like really scrunched up, so this actually happens quite commonly when the babies are doing skin to skin with their parents. They kind of get back into that like little fetal position when they're lying on their mummies. Or for example, if the baby's neck is like really super hyperextended, they're a lot more likely to have events. So it's important in these situations that you try to keep their head in kind of like a neutral position and make sure that that airway stays patent and they're not kind of all squashed up. Same thing if you've got issues with airway patency. So this could be like an anatomical issue like a choanal atresia, which obviously is a different cause of apnea. That's not apnea of prematurity. But more commonly what we do see in our little ones is just excess secretion. So whether they've got like a mucus plug in their nose or they've just been refluxing milk or whatever, and it just needs to be extracted. A lot of times you just hope that the babies will just kind of cough it out or sneeze it out themselves. We try not to put the bulb too much into their noses because every time you put that bulb in, there's just a higher chance that it's going to swell it up even more. But obviously if they've got like a big mucus plug there, you're going to have to suck it out. Number 3, what about outcomes of infants that had apneas? So what if a baby does have a lot more apneas than its neighbor in the NICU? Does it actually affect them in the future? Okay, the first thing that I'm going to repeat is that sometimes increased apnea is not because of apnea of prematurity. It's IVH or neck or seizures or choanal atresia or a million other things. So obviously that has to be addressed first. But what if all of those things have been addressed? The baby just seems to have worse apnea of prematurity than its neighbor. Do we have to worry about that? Well, here there isn't really great news. There's some pretty solid evidence that shows that the worse the apnea of prematurity for babies, the worse the developmental outcome. And the way that this was kind of figured out was the frequency and severity of events, or the number of days that the baby had apnea of prematurity, as well as the later on in life the baby had apnea of prematurity. So if the baby was still having events close to term versus the event stopped at 33, 34 weeks, then babies that lasted with apnea of prematurity longer had the worst developmental outcomes. Again, though, these were retrospective studies where basically teams looked back on how many events a baby had and then looked at their outcomes. It's not like this was a study done where a medical team was like letting one group of babies have as many apneas as they wanted and seeing whether those babies were going to do worse off than the team that had their apneas well controlled. Obviously, the medical teams taking care of these babies were ruling out other causes for their apnea. They were giving them the respiratory support they needed. They were putting these babies on caffeine, and yet these babies were still having more events than this other group. So really, there isn't a lot to do with that information. I think the take-home point is that events are bad for the baby. And yes, we know that all babies have apnea of prematurity, but I think sometimes it's easier to get a bit blasé about it. Oh yeah, that baby always has DSATs or bradycardias at this moment or whatever. And I think it's just a reminder that it would be beneficial for the baby if they had fewer events, less severe events. So maybe the other side of that is maybe we do have to give caffeine for a little bit longer, or we do have to keep them on a little bit respiratory support a little bit longer. Everything in the unit is just a balance. 4, when can we send babies home that have been having events? Well, in the US, generally, we want the babies to be off the caffeine, we want the caffeine out of the baby's system, and we want the baby to not be having events for a certain number of days before they go home. There are trials of babies being sent home on caffeine, and some brave researchers have shown that sending babies home on caffeine in the future really may be an option. In fact, there are 2 pretty big studies that are about to be published on this topic, and we'll see what it shows. But for now, at least, most of us want the babies off caffeine before they go home. So when do we actually stop the caffeine? So maybe we'll try to stop the caffeine when we know that most babies at that age will have grown out of apnea of prematurity. So like we said earlier, at 34 weeks, less than 20% of babies will have some level of apnea of prematurity. So I think a lot of times we stop that caffeine at about 34 weeks. Just remember though, like the studies have shown, that it's the tiny babies, so the babies that were born 22, 23, 24 weeks, as well as the babies that are still needing significant respiratory support, those are the ones that continue to have apnea of prematurity later. So if you have a 34-weeker who's still on high levels of CPAP and that baby was born at 22 weeks, then you should probably be continuing the caffeine at that point. As everything else in the NICU, we're always balancing everything out. So should we stop the caffeine at 34 weeks in a relatively healthy feeder grower and allow the occasional slight event, maybe a slight DSAT? Or do we keep the caffeine on for a lot longer, but also knowing that that may eventually delay discharge? And that is part of the important question. How long after you stop caffeine is it out of the system or at a subtherapeutic level? When you stop caffeine and how long it takes to get out of the system is very critical when you're deciding when to send a baby home. Let's say that you want the baby to have had no events for 5 days before discharge. So you want the baby to have had 5 event-free days. If the baby was on caffeine 6 days before discharge, then basically, can you count those first couple of days as truly being event-free? The baby was on caffeine, so maybe the caffeine was treating the events that the baby could have had. So what we really want is we want the caffeine to get out of the system or to a subtherapeutic level, and then once it's out of the system, then we start counting the 5 event-free days before the baby can go home. And a study done in 2018 showed how long it took for caffeine to get to a subtherapeutic level after it had been stopped. And they counted subtherapeutic levels to be less than 5 mg per deciliter of caffeine in blood. And as this table showed, in 44 infants, or 28% of the babies tested, the level of caffeine was more than 5 milligrams per deciliter 5 or more days after discontinuation of the drug. And logically, those babies had slightly higher doses before they were stopping. The authors of this study concluded that a large number of premature babies had therapeutic levels of caffeine 5 to 7 days after actually stopping the drug. So if we're truly waiting for event-free days, then maybe we should be waiting for at least 5 to 7 days after the caffeine's been stopped, and then we start counting the event-free days after that. So in all, maybe after the caffeine stop, maybe we should be waiting 10 days where an infant doesn't have an event before that baby can go home. The authors of the study also suggested that this might be the time where we would benefit from actually checking a caffeine level. So in a preemie baby that you're waiting for discharge because of events, it might be helpful to actually get the caffeine level and see if the baby's at a therapeutic level or not, if your hospital is able to do that. The other thing that I think a lot of us do is allow the babies to slowly outgrow their caffeine doses as they get older. So generally by the time that we're stopping the caffeine, it's not at a super high dose that's going to take longer to get out of the system. But maybe somewhere around 33, maybe even 32 weeks if the babies aren't having events, then I stop correcting the caffeine dose for increased weights for the baby. So I just allow them to kind of outgrow the dose. Then obviously it would take less time for that caffeine to get to subtherapeutic levels after we stop it. Generally though, I'll probably wait at least 7 days after stopping caffeine before the baby goes home. Again though, this is something that all needs to be decided and protocolized in your unit, just so that there's consistency for everybody. Everybody knows what's going on, especially and importantly, the parents of the babies. What about events that don't seem to be true apnea of prematurity? Well, again, we all deal with these a little bit differently. So if the events are happening during feed, so the baby's having a bradycardia or a DSAT during the feed, then generally we won't count these necessarily against the baby because the caretaker is right there and can do something about it. Generally, the baby will need more attention, whether they need better pacing or a different nipple or something, because this sounds more like aspiration or whatever, but it needs to be taken care of. But it doesn't concern us as much in sending the baby home because we know that the caretaker will be right there. But if the baby is fast asleep and has a 25-second apneic event and the heart rate goes down to the 60s, then that is a lot more concerning, and that is definitely something that we should be counting in this event. The scariest ones are when the babies are fast asleep, because we may not be there, we may also be sleeping, and so we won't know to stimulate the baby, obviously, when the baby goes home. But if the baby is sleeping and has a high bradycardia, so say the heart rate goes to 80 or 79 for 5 seconds, and then the baby brings himself back up immediately, then we shouldn't necessarily count this. It's less than 20 seconds and it was self-resolved. If anything, this is kind of reassuring that the baby's able to bring themselves out of it. The baby could have been straining to poop or just kind of vagaled a bit, choked on something for a second. So this is not something that we should hold against the baby. So we can see all the grayness in the events. When do we call it an event? How bad is the event? How long do we give caffeine for? When do we stop the caffeine? When do we send babies home? So you know roughly the details now. Again, it is so important that as a medical team, everybody in the unit decides to do the same thing. And before we finish, I have 2 homework assignments for you. The first one is come up with 5 reasons why a baby may be having apneas that is not apnea of prematurity. So 5 causes for apneas. And the second homework assignment is name 3 ways in which caffeine is beneficial for these babies. Comment below if you know the answers. But in the meantime, I really hope that you learned something. That was a long one. We are so thankful for you being here. If you want the summary, then sign up to our newsletter. Again, thanks so much for being here.